Good morning, everyone. How are y'all doing today?
Good.
It is dark outside. It makes me want to be asleep. It also seems that everyone else in the neighborhood is still asleep on spring break, so lucky for them. Today's class is basically a bummer. We talk about kid cancer. We talk about grief and loss. So I apologize, but the content is what it is. The nice thing about doing this through Zoom is if you need to take some time for yourself, if this touches you in either a personal or professional way, you do what you need to do. I usually tell students, if they need to step out for a few minutes and go out and collect themselves and come back, then, I totally understand that because it is difficult content. A lot of students, when they tell me that they could not work in peds, it's for situations like this. Okay. The other situation or other reason they can't work in peds is something that we're going to talk about tomorrow, and that's child maltreatment. So there are a lot of really great things about working in the pediatric population, but just like any other population, there are definitely some downsides, and seeing how cruel people can be, parents, caregivers, et cetera, can be to children, or the sad things that can happen through cancer can be really difficult. But like I said, if you need to take some time while we're talking about things, I completely understand. Just shut your camera off, do what you need to do, and come back. It's hard, but we'll get through it. If you have any questions as we're going, just let me know. We're going to start Unit 9, starting with some of our hematology issues. Okay. So looking at some of the factors, there's a lot of overlap, especially when we're talking about treatment. A lot of these conditions, we've talked about a lot of things that only happen in our pediatric population. You guys will probably be able to draw some comparisons to things that happen in the adult world, as a lot of these conditions are going to be something that you've heard of before. Okay. Just a couple reminders when we're talking about blood transfusion, the same rules that we use in the adult world, they apply here as well. We'll talk about some of the conditions that we use blood transfusions to help treat. But just remember, there's very specific things that we have to do. You guys going from LVN to RN, this is in most situations probably not something that you've had to do before. So just to make sure that you understand the rules when it comes to doing blood transfusions. We start with monitoring or verifying both the donor and the recipient's blood type. We can do a lab called a type and screen that's going to tell us what blood type that patient is. In most situations, we want to give that blood type that's specific to that patient, because that helps prevent any type of reactions. If we work in an emergency situation and there's not time for a type and screen, we can give that O positive, because that is O negative, because that is the universal recipient or universal donor. So anybody can take that. It is O negative, right? O negative. Yeah. O negative. Yeah. Sorry. I'm just confusing myself. O negative is the universal donor. Any patient can take that on without reactions. If we're working in a critical situation where we don't have time for that type and screen. Okay. The other thing that we have to think about is related to those potential transfusion reactions is closely monitoring our vital signs. And most hospitals are going to have their own protocol. You don't really need to get bogged down in any specifics on how often or how frequent that you need to monitor vital signs when it comes to blood transfusions for the purpose of this exam. What you need to understand is that you need to have a baseline. Before you even go and get that blood, you need that baseline. You need to know where that patient is starting from. Okay. So looking at your heart rate, your respiratory rate, pulse, your blood pressure and your temperature are all very important. Oxygen saturation too, because if that patient is going to have a reaction, that's how you're going to see it. Okay. Most hospitals or departments want you to get that baseline, and then you start your blood, and then about 15 minutes after is when you need your next set of vital signs. Most patients, if they're going to have a reaction, it happens within that first 15 minutes. Not always, which is why you have to continue to monitor. A lot of hospitals will do 15 minutes, every 15 minutes, a couple of times, and then they go to 30 minutes during the transfusion. And then typically we do a 1 hour after. Like I said, you don't need to memorize that schedule by any means. You just need to know you have to start with a baseline and you monitor them frequently. Okay. The next point says use appropriate filter. This is going to be dependent on your population. In the NICU, we don't use a filter. We just have our syringe full of blood. We connect that to blood tubing, and that goes directly to our patient's IV, right? In the adult world, you have to run normal saline as well. That's something that if you haven't covered in your med surg class already, you'll get to. Not something we have to do in every population, okay? The best case or best place you're going to go to find information on what you need to do for your specific population is to look at your department's policy and procedure manual, okay? Other rules that we have to do is blood is a 2 RN check. So one nurse, or you can send the unit secretary, whoever can go and get the blood, goes down with the appropriate verification documents to the blood bank, gets the blood, that gets back to the unit. And then 2 nurses go through and make sure that everything is correct. Okay. Before you even go get your blood, you do those baseline vital signs, but you want to make sure that you have everything set so that as soon as that blood gets back to the unit, you're able to start it, because you have to start it within 30 minutes of receiving it from the blood bank. And then you only get 4 hours max to give it. And that's the same in the adult population. It doesn't really matter what happens in the process of giving that blood. If your IV goes out, takes you an hour to restart it. The time starts from the minute that you leave that blood bank, and then it starts again when you start that transfusion. You have to do it all within that 4 hours, because the research shows beyond that 4 hour point, bacterial proliferation, or the growth of bacteria, expands rapidly. And basically you would be just pushing potential pathogens into that child or to that patient. So we have a strict 4 hour time frame. Some units may require you to start 2 IVs or to have a backup IV just in case it were to go out. Your primary line goes out while you're giving that transfusion. You can quickly move it over and not waste a lot of time. I have been in situations where I had everything set up, the blood is going, and then about an hour into it, my IV site gives out, have to stop the transfusion, restart the IV, and then that time is taken away. What this means, especially in the small population, is that they're not going to get the full dose of blood that they were ordered, which means most likely they're going to have to get another transfusion, which means another potential round of reactions. Okay. So we do want to make sure that we have all of our ducks in a row when it comes to that. The other great thing that comes to blood transfusions, and we'll talk more about this when we get into specific disorders, is we don't have to give whole blood. We talked in our GU and our dehydration conversations that fluid and electrolytes can get out of balance in our pediatric population very easily, especially when we're talking about that infant and small child. So giving specific components of blood like platelets, for example, is really helpful for our small population, because we can give them just what they need without potentially fluid volume overloading them. Okay. So we'll talk more about that as we go on. But just keep this slide in the back of your mind when you're preparing for this next exam. These are universal rules for all populations, maybe a few variations depending on, your vital signs or that filter, what have you, but starting within 30 minutes and using that blood within 4 hours, the 2 RN check, that's for every population when it comes to blood. Okay. All right, so the first condition we're going to talk about is anemia. Most of you have probably heard of this. This means that our red blood cell or hemoglobin concentration is below normal range. There are 3 main reasons that this can happen. All right, first, we have increased blood loss. This means that our patient has a big wound from trauma, from surgery, something like that, that is bleeding out. They're hemorrhaging. Right. The second factor is increased red blood cell destruction. This is typically secondary to some other process. All right. Third, we can have decreased red blood cell production, which can be secondary to another disorder, or can just be something that occurs on its own. Can also have a case of anemia that is a factor of multiple of those situations. Okay, so it's either related to increased blood loss, which is our hemorrhaging, increased red blood cell destruction, or decreased red blood cell production. Okay. When we think about patients that have anemia, there's probably a picture that comes to your mind, and that pale skin from that decreased circulatory volume, fatigue, cool extremities, other things
My
that
class.
tachycardia and tachypnea. Remember, those are two of our big, just gonna mute someone's not muted. Those are our compensatory mechanisms. So those, what we increase our heart rate, we increase our respiratory rate because we're trying to circulate more oxygen to meet our needs. Okay, so those are the acute symptoms that we see with anemia. When we look at more chronic concerns, again, it's going to go back to that decreased growth and development. Okay. When we have that low volume of oxygen circulating, that means less oxygen circulating through the body, but also means less to the brain, which means that children who have chronic anemia are going to have less amounts or less availability to grow, and that comes to their neurologic development as well. The difficult thing about anemia is it's based on symptoms. We don't, in the term child who's having no issues, we don't just do random CBCs or monitor their blood levels unless they're showing us that they're having an issue. So when we talk about that first year where that infant is going so often, it's a great thing for that pediatrician or for that nurse to try to hone in on. Okay. There is towards 9 or 12 months, there is a recommendation of getting a CBC. But if we don't have that notification through symptoms before that point, that's a lot of growth that child could miss out on. Okay. The other factor is increased risk of infections because the inflammatory or the the infection response is just not as immune response. Couldn't think of that word. Sorry. Is not as strong because there's not enough blood circulating. It can't mount that same response. And then we may see behavioral problems related to that lack of oxygen that's getting to the brain. So those early indications, the pale skin, the changes in the vital signs, parents or caregivers reporting fatigue, should be some red flags that we need to monitor this a little further. Okay, so the diagnostics, very simple. We're either going to do a full CBC to look at all of those blood components, or we could do a specific H&H. We could also do a hemogram that only looks at red blood cells, white blood cells, platelets, and that H&H for some more specific factors. But it's really the value of that hemoglobin that's going to tell you, is the child suffering from anemia? Okay, and remember, it can be an acute situation related, it can be secondary to something, or it can be just a chronic situation. Okay, so you can see the normal lab values for hemoglobin, 5 to 14 for the 1 to 6, I'm sorry, 9.5 to 14 for the 1 to 6 year old, and then 10 to 15.5, a little closer to adults for that older age. Okay, so we talked about the pale skin, fatigue, tachycardia, didn't mention murmurs. All right, the reason that we see those murmurs is because things kind of get, as the heart is working harder to pump that extra blood through, it can get a little clogged up. So we may hear that temporary murmur until we fix our situation. All right, so once we've identified that we have anemia, we want to figure out what's causing it. Is it something that is just happening idiopathically, meaning we don't know what's causing it, or is there something else that we need to look at? Okay. And then we can balance those. If it, there's specific types of anemia. We're going to talk about iron deficiency anemia in just a second. If it's related to a specific type of anemia, then we're just going to, take it, from there, if it's that iron deficiency or something like that. We can also give a transfusion to kind of boost the blood volume with the hopes that the body is going to get back to that situation where it's able to normalize its production. All right. Hopefully it's just a temporary situation. And then the rest of it comes down to supportive care. Because we're looking at that hemoglobin, that oxygen carrying capacity, these children may need some oxygen support. The IV fluids is to help boost the circulatory volume so the body doesn't have to work as hard pushing that blood through. Again, temporary. Decreased oxygen demands means that we keep that child as comfortable as possible. If he has periods where he's crying or upset, we try to soothe him quickly, because the higher or the more energy he's expelling, the worse this problem is going to get. Okay. All right, so now we'll specifically talk about iron deficiency anemia. This is a type of anemia that is related to iron deficiency, okay? It is the most prevalent and preventable disorder that we have here in the United States. The biggest factor is really just not providing that child with a well-balanced diet that is iron rich. If you look at a lot of foods that are geared towards or formula that's geared towards that infant, you'll see that it says iron fortified. The whole purpose behind that is to try to prevent that. So if we have a patient that is strictly breastfeeding, by the age of 4 months, they need to go on iron supplements because they need that support that they're not getting through the iron fortification in commercial products. Okay. Once we get beyond that year, then we start to look more at diet specific things. Again, just like the conversations that we've had in the past, we always want to go least invasive first, and providing iron through the diet is the least invasive method. Okay. So we start less than 1 year. We look at that fortified formula, fortified cereals, if necessary. And then as that child starts to take solid foods, or if we're looking beyond a year, then we start to look at how we can provide it. Leafy greens, same as we talk about in the adult population, eggs, meat, beans, all great ways of providing iron for that child older than 1 year. We can give whole milk, which has iron in there as well. If we go through all of that, all these dietary changes, we ensure that the child is eating those iron-rich foods. If that's not fixing our issue, then we can try some supplements, okay? The reason that we don't go to supplements first is because we want that body to be able to do the natural thing, okay? Whenever we provide that outside source, it means the body's going to start to rely on that, and it may take even longer for it to try to balance out. If it's needed, absolutely, we're going to go for it. The other factor and the biggest side effect when it comes to providing iron is the constipation that it can cause. Okay. Some children may not like the taste as well. I mean, if you've had iron pills in the past, you may note that it has kind of a metallic taste to it. I mean, it is a metal. And in our infant population, we have to go with liquid, which means they're going to taste it. So that can be a factor as well. If we do have to go to the supplements, we want to tell our parents to give the supplement on an empty stomach. The body usually tolerates it a little better. It's also more effective because it goes straight into the system that way. And then when we're giving that, to expect those black tarry, those dark colored stools, that wouldn't be a concern. Okay. And then, as I've already noted, for infants that are exclusively breastfed, we do want to start that because that's not something they're going to get from the breast milk. Okay. All right. The next type of anemia we're going to talk about is sickle cell. There's two kind of things that are two ways that we can look at that. Sickle cell anemia is a specific type of sickle cell disease. So sickle cell disease is a collection of disorders that involve sickled cells. Anemia means that we've got that problem where we don't have enough blood cells. Okay, so specific type here. There's a genetic connection here. So if we had parents who knew they were carriers, we could do genetic screening early on. As soon as that woman is pregnant. Or if we didn't know that, if they were carriers, they didn't know that there was a family history, then we would be able to spot that on the newborn screen. So this is something that's standard on newborn screens across the country. to give us that early sign. May not be something that we're seeing symptoms of from the, immediately from birth, but something that we would want to be aware of as we start to see those symptoms. We can get on it immediately. That child that is positive for sickle cell from that newborn screen is going to go through more testing than a child who's not positive would go. Okay. When you guys think about sickle cell, what you are probably most familiar with is that picture of the sickle cell crisis. Okay. So that I've got a picture on the next slide if you're not familiar with that shape. But there's a specific shape, that sickled cell that happens with this disorder, and it causes it's decreased hemoglobin carrying capacity, but also causes pain as it's moving through those vessels. Okay, so you're probably familiar with that painful picture. What's happening in this crisis is that we've got that increased destruction of our normal healthy red blood cells and increased production of sickled red blood cells. So we've got a decreased circulatory volume, but we've also got decreased oxygen carrying capacity, and that's what puts that child in the crisis. Okay, so typically this is a very painful disorder, especially when we're in that crisis. The best thing that we can do to prevent that crisis and to treat once that crisis happens is adequate hydration. Okay, so we always focus on oral first, but once we get to that crisis, we may have to bump it up to IV fluids. Okay, so you can see our clinical picture here. And again, this is the same thing that we see in our adult population. Okay, so we've got risk of stroke because those sickled cells can block normal pathways. They can create clots. Those clots get loose. They circulate through the body. They may go to the lungs. They may go to the brain, and that's where our stroke would happen. Okay. Chronic, we're looking at potential retinopathies. You may see hepatomegaly. That splenomegaly is very common. We'll talk about that splenic sequestration in just a second. That's one of our big complications. You can see some other issues. Pain, pain is just all over here. You can see it in the bones. You can see it in the abdomen as well. The further this, or the more aggressive this sickle cell anemia is, the bigger or the more difficult it is going to be for that child. Okay. So if you look at page 1277 in your new textbook, let me get the page. Oh, sorry, it's 1277 in the old textbook, 1274 in the new textbook. Looks at the different symptoms. So you can go a little bit further into that based on the body. Okay. So when we're talking about that sickle cell crisis, I said this is what happens when we get to that point where we've got increased red blood cell production, but also decreased red blood cell production, increased sickle cells. So decreased oxygen carrying capacity and that pain. So if we look at a vaso-occlusive crisis, this is that painful experience where those sickled cells are basically scraping against the vessel. Okay. Other symptoms that we see with this patient, tachypnea, shortness of breath. The older child may complain of headache and dizziness. All right. That splenic sequestration, we've got blood that is pooling in the spleen. Okay, we know that our spleen is responsible for helping our red blood cells get developed. So if we have blood that's pooling in there, that's going to affect that process, right? What we likely see in these children is irritability, that fatigue, weakness that we associate with anemia in general, splenomegaly. So that spleen is going to feel enlarged when you palpate on that abdomen, pain on the left side of the abdomen from that spleen. And then you'll see other traditional signs, that paleness and tachycardia. Okay. With aplastic means that we just have not enough red blood cells. Okay. So go back to your clinical picture of anemia, and that's what you're going to see here. Okay. Tachycardia, shortness of breath, fatigue, dizziness. We're going to add in petechiae in here as well. Okay. we look at our complications, we already talked about the stroke, the risk factors or the identification of, sorry, my nose itches, identification of a stroke is the same that we use for our adult population. If you're not familiar, we have an acronym called FAST. So we look at that face drooping, the arm weakness, speech difficulty is our FAS, and that T is time to call. I want to keep in mind that time equals brain, right? So the sooner that we can break up that clot, restore normal blood flow to the brain, the least likely or the less likely we are to have permanent neurologic complications, all right? The other situation is that acute chest syndrome. What's happening here is the pulmonary vasculature has been affected related to chronic oxygenation. All right. This child is going to complain of chest pain. You may see a cough, fever. That hypoxia is very common. And then on X-ray, you're going to see lung infiltrates, which are going to look like little patchy white parts. Or white spots on that X-ray, okay? So what are we going to do for this child? A lot of it is that hydration based, right? We increase our circulatory volume through IV hydration. That's going to help both with the pain and increasing that circulatory volume. It may IV fluids increase your volume. So the needs to go to the bathroom are more frequent. One thing that you would want to keep in mind is safety as far as getting that patient up, knowing that they're fatigued, knowing that they could be dizzy. So presenting them with a safe, checking in on them frequently, ensuring that the parent or caregiver is able to safely get them up into the bathroom whenever they need to use the restroom. And also know that nighttime bedwetting may happen for our child that is potty trained. We can do some things to prevent this. Maybe they sleep in a brief. Maybe we wake them up. We'll talk with the family to see how they want to address that to try to prevent that from happening. Okay. We've talked about the need to decrease those oxygen demands. Basically, we just want everything to be in homeostasis. So if they're having trouble breathing, we're going to facilitate that with however we need to, providing them with oxygen. We want them to rest as much as possible. So we don't really encourage them to be up and active. We want to try to entertain them or provide them with some options of development or doing something that doesn't require a lot of energy. They probably aren't going to feel like doing much of anything anyway. So this part isn't usually a fight. All right. The next big focus comes to pain management. Like we already covered, this can be a very painful experience. So typically very cautious on providing pain medication to most of our pediatric population. This patient is going to get some leeway when it comes to that, knowing that this is such a big component of this disorder. All right. Then we come to preventing infection. All right. Encouraging immunizations, not so much in the time of crisis, but when we're a healthy point, ensuring that we stay within those recommendations to try to prevent things that we can. Penicillin prophylaxis, anytime we are at risk, if we're getting our teeth cleaned, if there is some surgery that we need to have done, going above and beyond with that, infection prevention is going to be really important here. Okay. If we're dealing with a patient that has that frequent splenic sequestration, or we're seeing that become a bigger issue, we may have to take out the spleen, right? Blood transfusions, same protocols we've already talked about. Just this is a temporary situation during that crisis to try to boost that blood volume. For patients that have many crises, we may talk about stem cell transplant. All right, we're going to talk more about that a little bit later. But the reason that we are very cautious, we don't just say, okay, you're a child with sickle cell, let's do a stem cell transplant, is one that they're not always available. All right. And we can get ourselves into a situation if there's a reaction to those stem cells that it's hard to get out of. But we'll talk more about that in a little bit. for teaching with our parent and caregiver, we want to make sure that we are providing those early signs of infection so they could get that child treatment before it becomes too advanced. And then we talked about those complications of acute chest syndrome and that stroke. So ensuring that the parents or the caregivers know the early signs of that so they can get that child help as well, trying to look at that early treatment there. All right, the next situation we're going to talk about is hemophilia. Again, something you have probably heard of in the adult population. There are two types of hemophilia. We're going to focus on type A because it's the most common. Okay, this is our factor VIII deficiency. It's important for you guys to understand that hemophilia is not a situation of patients bleeding more, it's a situation of patients bleeding longer. Okay, that's a really important thing for you to understand. They don't have that factor VIII, which is so important in their clotting, which is why they bleed longer. Okay, so signs that you're going to see that prolonged bleeding, simple things like a paper cut bleed a lot longer than they should. Active hemorrhaging, if there's been a bigger issue that's hard to stop. Bruising, and bruising can be hard to distinguish. Is this normal bruising or is this more? But this is the child that barely touches anything and there's a massive bruise there. Okay, not the normal bruising that we associate with our development of moving, but this is going to be very, you touch the child, you move him from one position to the other, and even just your gentle touches is going to leave bruises on him. Okay, hemathriosis is bleeding in our joints, not really something that you would be able to pick up on as far as visualization other than swelling or that older child reporting pain. Okay, and then spontaneous hematuria, just suddenly there is blood in the urine. All of these are big red flags. Most of these would probably freak parents out to the point where they would take them in to figure out what's going on, especially that blood in the urine. That's a pretty big, scary thing that happens. So typically that's when that would be identified. Hemophilia is not something that we screen for on the newborn screen, so not something that we would know. So it would be based on the clinical presentation. If we had a parental history, we may be more in tune to follow that, but most of it's just we'll diagnose it when it happens. Okay, so we look at our clotting factors, and then we can look at that DNA because there is a genetic link here as well. Okay. When we look at our treatment, biggest thing is to prevent bleeding. Easier said than done, honestly, but preventing things like contact sports in our older children, we're trying to be more mindful of potential accidents, is going to be a big factor here. All right. Replace clotting factors when we are seeing that is necessary. Earlier, we talked about with our blood transfusions, one of the great things that we can do is just give specific components. Here, we don't have to give whole blood. We don't have to give red blood cells. This child just needs factor VIII. And that's something that we can do. Same protocol for blood transfusions, where we can literally just give that component there. And that would be all that child needs if we're going to replace that. Okay. If we're severe, we may replace platelets as well, but we're going to start with that factor VIII. All right, other medications that we may give, corticosteroids, we know that helps with our inflammation. NSAIDs may help with that pain that we're seeing in the joints. We do use that cautiously, especially in our younger children. We want to make sure that, we don't want the child to be in pain, but we don't want to go crazy with the NSAIDs that we're giving. Okay. And then that DDAVP. This is a medication that has multiple uses. You may see it used in diabetes insipidus that we'll talk about in a couple weeks. But based on what's going on as far as our pathophysiology with hemophilia, DDAVP or desmopressin causes the release of von Willebrand's antigen from the platelets, which increases the clotting capabilities for that child. Okay. So that's another medication that we can use. Regular exercise and physical therapy are going to help keep that blood flow moving effectively. We just want to be cautious on the activity. Okay. If this parent were to ask you what would be a great activity or sport for their child to get engaged in, we want to avoid anything like baseball, soccer, football. All of those are highly contact sports, but something like swimming could be a great option here. Okay. Control bleeding when it happens. We want to be on top of it. This means that every person in that child's life that may provide care, babysitters, daycare, school nurses, etc., would need to know that this is something that this child experiences, so that we can provide the care whenever it's necessary. Okay. It could escalate to a situation where that bleeding doesn't stop. And that's the point that we would want that parent or that caregiver to seek emergency help. They're going to need some support. They're going to need those clotting factors or something like that that's going to help that bleeding stop. All right. It doesn't happen every single time, but there's a certain point that bleeding goes on. We can't stop it, that we need to seek that care. Okay. That is the last condition that we talk about with hematology. Does anybody have any questions about heme before we move on to oncology?
What will be patient teaching for this?
Big factors is trying to prevent the bleeding, and then being on top of the bleeding when it does happen. Knowing that, I mean, even things like I said, the simple paper cut, you're going to have to put pressure on it. And then every physician may have their own recommendation if the bleeding goes on for 15 minutes, or they may have a certain saturation point. You don't really have to know that information because that's very specific on the case, but knowing that at a certain point, if the bleeding doesn't stop, that's when you seek emergency help, is really the point that you need to understand here. That help?
Yeah, and what is the RICE?
So RICE stands for rest, ice, compression, and elevation. So
You would do-
when we're talking about the bleeding, if we elevate something, that gets the blood flowing back to the heart, helps alleviate bleeding, may stop things a little bit faster. Compression puts pressure on those vessels, so it can stop that as well. And then ice is a vasoconstrictor, so it can stop the bleeding faster as well. So it can be done as if they sprain their ankle or something like that to prevent that hemoarthritis that we talked about, but can also be done if there's bleeding, we just elevate it, and that helps stop the bleeding a little faster. Any other questions? No. Let's take a 5-minute break. We'll come back at 8:15 and start on our oncology. Okay, let's move on to chapter 44. So we'll talk about pediatric oncology. Obviously, there are many different types of cancer, and we're going to talk about some specific ones. When we're looking at those early signs, there's some red flags that we see in our assessment that we would want to be identified from, would want to identify early. Just like every condition, the earlier we can identify that, this is what's going on, the best chance for a good outcome or that better prognosis that we can hope for. Okay, so some of our general findings: that unusual mass or swelling. This could be in the abdomen, this could be on a bone, unexplained pallor or decreased energy. Those factors sounds a little like anemia. That would be one of the first things that we would test for. Okay, that may lead us into further lab diagnostics that might identify that we're dealing with cancer. Okay, sudden tendency to bruise, we would rule out hemophilia, like we just talked about. That's often linked to leukemia. Persistent localized persistent localized pain or limping. Sometimes this is shrugged off as just growing pains, depending on how old that child is, but can be a big red flag for bone cancer. Prolonged unexplained fever or illness, especially if we can't really identify a cause, can be a big red flag. Frequent headache, often with vomiting, could be some type of neurologic or brain cancer. Sudden vision changes could be related to retinoblastoma. Excessive rapid weight loss could also be a big red flag. So these would just be things that, the parent or caregiver comes in and says, this is what the child is experiencing. That would hopefully clue us in, and we could start in on our diagnostics. Okay, could see some of the things that we have linked there. CBC is going to help us look at potential leukemia. CMP is that complete metabolic profile, may help us identify some situations. Most of these labs are designed to rule things out. So as we're seeing, okay, it's not anemia, it's not hemophilia, that is going to take us into that next path. So a lot of it is about ruling things out to get a better picture of what's going on. Okay, can also look at the liver function test, the coags. That LP is helpful in identifying. That lumbar puncture is helpful in looking at leukemia, because we can look at some specific markers in there. Brain tumors may be highlighted because we're looking at that CSF. We may see some of these components in there. May also show it that METs there, that's metastasis components. What happens, just in case you're not familiar with metastasis, the cancer has started in one area, and when it's metastasized, this means it has moved into another area. So we could have started with leukemia that metastasized into brain cancer if we didn't identify it quickly enough. Okay. Radiology is also really helpful, especially if we're looking at solid tumors. So X-ray, CT, MRI, PET scan is very helpful if we think there's metastasis. So it's typically a full body scan where we look at anywhere that cancer could be. Okay. Biopsy is what we do when we find these tumors. We're going to go in, we're going to pull out some of that tumor, we're going to send it off, and we're going to look for those tumor markers in that sample, that tissue sample. Okay. If you look at page 1300 in the old textbook, or 1302, we look at these cardinal symptoms, but they're things that don't tell us what type of cancer. They don't really even confirm that we have cancer or that our child has cancer. They're just big red flags that warrant further investigation. Okay. All right. A lot of students get really bogged down or in their heads about treatment. We're going to talk about some specific types of cancer, but what you need to know about treatment is basically what you see there. Okay, our options are surgery. If we're doing surgery, we want to try to get as much of that tumor as we possibly can. You may have heard of something called clear margins, just in different conversations. whether here in your job setting. What clear margins means is that we're able to remove all of the tumor. So any of the surrounding tissues, any of the surrounding cells, there are no more cancer cells. That is when we look at our best, prognosis when surgery is involved. That's what we're looking for. Okay. Other things that we can do: chemo, radiation, that BMT we're going to talk more about in just a second. That's body modification, basically biomodification, so specific medications that we can give. We'll talk more about that in just a second. Okay. So when we're doing surgery, our hope is that we can cure it, but it may also be palliative. Okay. When we're talking about palliative, this means it's not curing that cancer. It's just going to make that child more comfortable. Okay. This is something that we often do if we have advanced metastasis and we're not going to get to a point where a combination of surgery, chemo, and radiation is going to save that child. We're really just trying to make him as comfortable as possible. Okay, so we'll talk about some more specifics as far as treatment, but what I need you to understand is those 4 up there. That's the big components there. When we talk about these specific situations, you don't need to know the medications. You're not going to be tested on that. We'll talk about them, but this is what you need to understand for treatment. Okay, and like we already covered, the earlier we can identify this is what's going on and start our treatment, the best potential prognosis we have, right? The other thing that you need to understand related to treatment is the side effects, okay? This is important because 1, you want to identify them, but 2, you want to be able to provide that child with some type of nursing care, provide those caregivers with some instructions on how they can minimize the effects of these, okay? So because the chemo and the radiation basically attacks the body, it kills healthy cells as well. It's not able, I mean, the therapies are getting better. So they're getting to a point where they're able to target things a little bit more effectively. But as a whole, we're killing good cells as well. This is why we see things like hair fall out, and we see these children get pale, and we see them more at risk for infection because we're killing healthy cells as well. So infection prevention is a big factor here. So we teach these patients and these caregivers ways to prevent that, staying away from people that we know are sick, being very diligent with hand hygiene and any of those potential infection risk factors. Give them those early signs of infection and know that we have to be aggressive when it comes to treatment because that infection can go from just a small cold to full-blown pneumonia, for example, in a very short amount of time because that body does not have any immune response that they're going to be able to mount to that. Okay, hemorrhage is also a big factor here. So monitor for bleeding. We may have to transfuse platelets more often than in our normal population because they're not going to be able to clot effectively. Anemia is a big factor because, like I said, we're killing those healthy blood cells as well. So monitor for it, look for those early symptoms and transfuse as necessary. Nausea and vomiting, also very common. We can provide antiemetics to prevent that. But we also want to encourage that child. I mean, most children going through, or most people going through chemo don't really have any desire to eat. You know, we talk about sometimes when children get to really go crazy with whatever they're willing to eat, parents just can push cookies, you know, whatever that child will eat, because we just want him to take some calories. Okay. We use those preferences as much as possible because at the end of the day, we just need this child to eat. Okay. With that nausea and vomiting, we're also going to monitor for signs of infection in our pediatric population, dehydration. We have talked about how easy it is for the child to get fluid imbalanced, something very, can happen very quickly in our child that's going through chemo or radiation. All right. If we can't get that child to eat, we may have to think about some altered nutrition. We may start a G-tube or some other ways of feeding that child if they're unable or unwilling to to eat things by mouth. Okay. May also help with the nausea and vomiting. To do frequent small meals may help. That next point, you see mucosal orientation. The mouth, I mean, it's killing those good cells too. So we see some at the edges of the mouth here, or inside the mouth as well, which if we have a child who already doesn't want to eat, this can make this even a bigger issue here. So we encourage them to have cooling foods or liquids. Popsicles usually are very well received by children. I mean, they're tasty, but they're also a great way to provide therapy at the same time of providing a small amount of hydration. Okay. Neurologic problems can also be a big factor. The effects, you may have heard of something called chemo brain. This is something that can happen where people aren't really able to process thoughts very effectively. May also see things like constipation related to bowel innervation, meaning the nerves are basically interrupted from the chemo or radiation. So we do things like give a stool softener, encourage physical activity, the same things that we do after a surgery or when there's limited mobility that may help stimulate those bowels. We may have children that are at experiencing that paresthesis or that muscle weakness. This is going to increase our likelihood of needing to follow those fall risk guidelines a little bit more closely. We may also have some pain related to the treatment that they're getting. So we may follow them closely with that pain therapy as well. All right. There's jaw pain that's often associated with chemo. And if we're talking about jaw pain and potential anorexia, where all of those things are going to kind of coincide, making that child less likely to want to eat. So providing some medication, some pain relief for that jaw pain may encourage that child to eat more. Okay. And the last one, we have hair loss. In the pediatric population, we really just base this, what we're going to do about the hair loss. I mean, we can't really stop it. It's going to be part of the treatment or it's a side effect of the treatment, but how that child responds to it is really what we're going to do about it. Does it bother them to the point that we need to look at hats or wigs? It's really just where that child is at developmentally that really determines how much is this going to affect him. Okay. And when we have children, I mean, sometimes they may be inpatient for these treatments. If there are other children around them that look like them that are going through these same things, it may not bother them as much as if they're the only child that's going through this, that's losing their hair. It also is heavily tied to Erickson, how much this is going to affect them. So that's something to think about as well. Excuse me. All right, so now we'll talk about, we'll talk about some specific types of cancer that you need to be familiar with. One of the most common pediatric cancers that we see is leukemia. There are two different types of leukemia that you can see listed there. We have ALL, which is acute lymphocytic leukemia, and we have AML, which is acute myelogenous leukemia. Okay. When we look at the survival rate, there's a huge difference between these two types. If you had to pick the type that your child was going to experience, they had to have leukemia, ALL would be the preferred kind. Okay. The survival rate is up to 80% for ALL now. It is the most common type of childhood cancer. What we're looking at with leukemia is we've got our disorder is in the lymphatic system and the bone marrow. So the cancer actually attacks those. So this is why we see that child look pale. We see him fatigued because it's literally attacking his blood cells. Okay. AML makes up about 20% of leukemia cases. And the survival rate is much lower. Hard to put hard numbers on this one because it's really dependent on how old the child is when he's diagnosed. His sex also makes a big difference as well. His race and the aggressive nature of that type of cancer can be a big factor here. So what I want you to understand from this slide is ALL has a better prognosis. Up to 80% will survive their first bout of leukemia. Much lower prognosis and survivability with AML. Okay. All right, so what are we going to see in these children? Anemia, infection related to that low response from the white blood cells because they're being attacked, bleeding related to low levels of platelets, enlarged organs, especially that spleen, because it's trying to rebuild the blood supply, so it gets inflamed and enlarged. The fever, lethargy, malaise we see as a combination of that anemia and risk for infection. Petechiae is that pinpoint bruising that we see. We can see this in the eyes. We can see this on the skin. If that child has leukemia and has a hard coughing fit, has vomits or something like that, we may see the petechia in the eye. Okay, weight loss is another big red flag. Most of these are part of that generic list that we talked about when we first started this part of the lecture. So we're going to have to go into those diagnostics to see, is this what's going on? Okay, so we start with the first thing, it's not listed, but we would start with the CBC. This is going to confirm that anemia. It's going to show us why we're having issues with our bleeding. From that, we would take that blood and we would do a peripheral blood smear. This is going to allow us to look at the specific picture of the slide of the blood and tell us what's going on there. Okay, then we would do a bone marrow aspiration. That's usually confirmatory. We're able to look at that collection of blood cells, and this is going to tell us that we have cancer causing cells in that bone marrow. Okay, LP may also be helpful as well. What are we going to do about this? All right. So we're going to do chemotherapy. We can do that through IV. We can also do intrathecal, which means it goes through kind of like if you think of like an epidural, kind of similar to that. There are 4 phases here. I'm sorry, 3 phases here. First, we have induction. All right. This is where our when we first diagnose leukemia, this is where our treatment starts. All right, what our hope is to obtain here is remission. So we want to see the symptoms that helped us lead to our diagnosis. We want to see those dissipate or decrease. We also want to see less of those cancer-causing cells in our bone marrow. So we'll do another bone marrow biopsy to look at that. If we're getting to remission, that means that we've got less than 5% of those cancer cells in that bone marrow aspiration. Okay. The next phase is intensification. So the agents that we use here, the medications, like I said, you don't really need to get invested in that. But just know in the second phase, what we're doing here is really blasting any of those remaining cancer cells. Okay. So this is basically, you know, the child comes in inpatient during that induction period, and he's usually there for a couple of weeks. Okay, this is 1 to monitor those effects, but 2 to make sure that he's in a protected environment while we're hitting him hard with cancer with chemo. Okay, and then that intensification, it's kind of pulses. So still high doses, but not for long durations. Okay, so we still attack those cancer cells so they don't have the option to rebuild their level, right? In that maintenance level, this is if we're in remission, this is where we're just really trying to maintain. We follow these children very closely, but the frequency of how often we have to do this really just depends on how aggressive their form of cancer is. It requires regular medical surveillance. They may not get the chemo every single time that they go in, but they're being closely monitored through lab work to make sure that the cancer is not being able to come back. All right. So that bone marrow transplant I've mentioned a couple times. We're going to talk about it more here. If we have a child with leukemia who doesn't respond well, then we respond well to the chemo, then our options may be limited to a bone marrow transplant. All right. Just like we see in organ transplantation, there's a huge potential for rejection here. Okay. The other downside here is that children have to be monitored in the hospital for several weeks before, during, and after the bone marrow transplant. And it's rarely just a one and done, right? It's not just one-time dose of these bone marrow and it's going to fix the situation. We also have to monitor for all of the effects that happen related to the rejection treatment medications, that decreased immune response, the increased pain, all of those factors that happen there, which is why we keep this child in the hospital for a long time to make sure he has a good response to that transplant, and that he is not suffering from any of those complications. Okay. When we talk about the nursing management, that anticipatory guidance, trying to provide parents and caregivers and the child, if he's able to understand with kind of what to look for, what may happen next, is going to be a big factor here. It's cancer. There's a lot of fear that's associated here. Could be just the idea of cancer, could be that there's a personal or another type of experience that this family has gone through. But it tends to hit people really hard. I mean, it's their child. So there's a lot of angers, a lot of feelings that happen here that the nurse would need to help these families explore and kind of work through. All right. Managing side effects. We talked about that already. That's going to be a huge factor here, trying to keep that child as comfortable as possible, trying to encourage nutrition and hydration, even when that's really the last thing that child wants. All right. Decrease infection risk. Child needs to be in a private room, not a great candidate to go out to the multi-child playroom. We need to provide him with entertainment inside his room. Hand hygiene is really important, and then monitoring his visitors to make sure that they're not showing any signs of symptoms. A lot of hospitals will actually screen, think about the way that we were screened to enter buildings when COVID was at its highest. A lot of visitors get that same treatment when they're going to visit children that are getting chemo because the risk is so high, right? Age restriction may be a factor, may prevent siblings or cousins or that kind of thing from coming in, because the likelihood of them having some germ on them is very high based on that population. Okay. All right. The next situation we're going to talk about is called a neuroblastoma. This is the most common type of cancer that's diagnosed in infancy. It's often called a silent tumor because we don't usually get the diagnosis for this until it's metastasized to a point where we're not really able to treat it, right? Very, very poor prognosis here. It is the most common extracranial solid tumor. So solid tumor outside of the brain. Can see that the primary site is the abdomen. What you need to understand, you can see that it's bolded here. We're going to talk about another type of cancer that does not cross the midline, but when we're looking at those symptoms that are specific to one disorder, neuroblastoma, most common in the abdomen, but it does cross the midline. Okay, so we can see that tumor extend. This poor baby looks so sad. We can see that tumor go all the way across the midline of that spine area, which would tell us that it's a neuroblastoma and not this other one we're going to talk about in just a second. Okay. Other big things to look at here: firm, irregular, non-tender mass is a big red flag symptom for this one as well. Okay, it doesn't cause pain. The pain is related to basically that swelling, right? We're going to see difficulty breathing, difficulty eating, but all of that is related to the size of that tumor. Okay.
You said it crosses the midline or it doesn't cross the midline?
It does cross, right?
It does.
Under manifestations, you can see in bold, it crosses the midline. About halfway in the page. So it does cross the midline. Diagnosis, we can see that tumor on CT. We'll also do a bone marrow aspiration, which would help in the early signs of this, that it would tell us that it's neuroblastoma as opposed to another type of cancer. If we don't catch it until that metastasis point, most of what we do as far as our nursing or medical care is going to be related to palliative care. Okay, so not really the goal of curing this, but of trying to make this child the most comfortable that we can. Like I said earlier, with surgery, our goal is to get all of the tumor if possible. If this has metastasized, we're removing that tumor for comfort. We're not going to get to a point where we're able to effectively treat and cure this child. Okay. Again, if we catch it early, we would follow that surgery with chemo to kill the rest of those cancer cells, prevent them from coming back. Nursing interventions, regardless of where we're at in our staging, is going to be about pain relief. And again, the pain is not related to the tumor because it's a non-tender tumor. The pain is secondary to what that tumor is pressing on. Okay, so you can see his large abdomen, that swelling is going to cause pain, right? It's going to push up on his diaphragm. It's going to push on his stomach. All of that fits into our supportive care. So this child may need oxygen. This child may need decompression, which means we're going to try to remove as much air from his abdomen as possible so that he's able to eat. And then we let him rest as much as possible. It's also going to be a lot of care for our parents, especially if we don't diagnose it until it's metastasized. So then we have to provide that anticipatory care as far as what's going to happen as this child is unable to fight this cancer. Okay. All right. The next cancer we're going to talk about is a bone tumor. We call this osteosarcoma. This arises from our osseous tissue. It's our most common type of bone tumor. We're going to talk about a second kind in just a second, but let's focus on this one first. You can see our peak age is 15 years, happens in boys more often than girls. The reason this one can be a little hard to diagnose is because you look at that age where we're seeing a huge growth period here. A lot of providers will kind of push this off as growing pains because the child complains of that, but they're also growing. It's easy to say that is the issue. It's going to take the discerning nurse or the persistent parent to really get a good diagnosis here. Okay. We do see the femur as the most common location. Pain is at the affected site. So wherever that cancer is, that's where that pain is going to be felt. Children are going to say that the pain feels severe, but kind of feels like a dull ache if they're able to describe it for you. Okay. We may note that with their activity that they limp, they may be able to identify that it's related to the pain if they're older. And depending on the growth, we may also actually be able to feel that. A lot of these tumors can happen on the growth plate, which means that it's at the end of the bone, so can be a little bit easier to feel. All right. Diagnostics, we look at X-ray, CT, MRI, all of those can help us identify that this is what's going on. Our treatment, again, based on how early we're able to identify it, we want to preserve the bone if possible, but we have to get rid of that cancerous part. It does come from the osseous tissue, so should we be able to diagnose it early, we may be able to preserve most of the bone, and then kill the rest of the cancer with chemo. Okay, we may catch it later, and it means that we would have to amputate. Part of our nursing care, if amputation is required, would be talking about potential prosthesis after that area has healed. Okay. All right. The other type of bone tumor that we have is called a Ewing sarcoma. So unlike that osteosarcoma that comes from our osseous tissue, this one actually comes from the bone marrow. Okay. So we see this often in the long shaft of the bones in our extremities. We may see it in the trunk as well. It almost always occurs in people under the age of 30. So this is definitely a pediatric or early adolescent type of cancer. Treatment is the same. All right. Because it's in the bone marrow, it's not really a surgery that we can use that's going to help here. But we can do radiation and chemo. Limb salvage or trying to save as much of that limb as possible is all again going to depend on how early we're able to diagnose this. Okay. So we see that same complaint of pain. This one's a lot harder to diagnose because because it's not in the osseous tissue, it's in that bone marrow. The symptoms aren't as obvious as they are with the osteosarcoma. All right, so now we're talking about a Wilms tumor. This is our most common kidney tumor. Remember when we were talking about neuroblastoma, it is that one we said is able to cross the midline. This one is only confined to one side. So from that initial assessment, if we're thinking cancer, it would be a big way from that early assessment to be able to identify that we're looking at Wilms tumor as a possibility rather than neuroblastoma, okay, because it is confined to that one side. The left kidney is the one that is most often affected. The other big thing that we see is this is a painless firm mass. Okay, so it's deep in the flank area. As you're palpating on that patient's stomach, you're going to have to palpate pretty deep. But the big difference here is it is confined to one side. So you're going to only feel it up to one side of the umbilicus and not on the other side. Okay. Other signs that we may see, that weight loss, fever, anemia, lymphadenopathy, those aren't really helpful in determining that this is Wilms tumor. It just kind of helps point that side towards potential cancer. That hypertension is a big red flag here because the kidneys are affected. That can be a big red flag symptom that happens just with Wilms tumor and not any of the other types of cancer that we've talked about. Okay. Diagnostics are very similar. That CT, MRI, ultrasound of the abdomen is gonna highlight that kidney that's affected. The CBC would show us polycythemia, which means we have an abundance of red blood cells. We'd also do a UA or urine analysis, and that isn't really going to be diagnostics. It's really just going to help us see how well the kidneys are functioning. Anything that we may need to do as far as supportive care for that child to maintain or preserve our kidney function. Okay. When we talk about our management here, we're going to have to remove that affected kidney. Okay. We will follow that once the child has healed from the surgery. We're going to follow that with chemo to make sure that we get any potential metastasis. A couple nursing considerations that we have to keep in mind. You can see it's in bold print, which means it's really important. Do not palpate abdomen. The first sign that we have that this is Wilms tumor, that is the last palpation that child gets. Okay, that's because when we palpate that area, we actually can disseminate or push those cancer cells into other parts of the body. Okay, so we want to not do that. So initial identification, we're thinking Wilms tumor, okay, then we need to post a sign in the room. We need to be very careful when we are handling this child, bathing, etc. Because any pressure on that kidney, that affected kidney, can push those cancer cells out into the rest of the body. Okay, which means obviously it's going to be a lot harder to treat. All right, so we said that we have to do surgery. We have to remove that kidney. The same post-op concerns that you always have following surgery are important, right? Always ABCs first. The next one that's going to come with Wilms tumor specifically is about your kidney function. Okay, so always ABCs. Then we look at kidney function because we are down to one kidney, which means that remaining kidney has to function correctly and effectively. Otherwise, that child's going to dialysis and going to need a kidney transplant. So our goal is to try to prevent that, especially knowing that we still have to go through chemo. That's going to be really hard for that child to deal with and to come back from. Okay, so always ABCs, then kidney function. So follow that very closely. After monitoring or after, we're looking at our priorities here. After kidney function comes risk for infection. Okay, that's the little bit of change here. Typically it's ABCs infection when we're talking about post-op concerns, but because we've removed a kidney, we're down to one. It's ABCs, kidney function, then infection. Okay, everybody follow that?
So would you say that one of the ABCs that's an alert would be high blood pressure first?
Yeah, I mean, that is part of your circulation. So
Like if they're giving you a list of signs of vital signs, blood
Yeah.
pressure is going to be very high. It's going to be an alert.
Yeah, absolutely. Yeah. All right. The last type of cancer we're going to talk about is a retinoblastoma. So this is cancer of that retina. This is caused by a mutation in gene, nothing that we can screen for. This is something that we diagnose based on the symptoms. Average age of diagnosis is 2. What you're seeing in that picture there is leukocoria, or that cat eye reflex. We've got a white glow. In patients with light colored eyes, you may be able to see this without any additional manipulation, but it may take looking at it with an ophthalmoscope. If we think about that red reflex that's supposed to happen when we look at the eyes with the ophthalmoscope, this is that white reflex. Okay, those of you with light eyes may have seen, you get your picture taken with a flash and it turns your eyes kind of that red devilish looking appearance. That red eye, that's that red reflex coming through. In a child with retinoblastoma, in that same situation, you're going to see that white glow. So as it gets more advanced, that white glow becomes more present without any of those additional testing methods. Okay. So again, the hope is to identify it earlier rather than later. All right. Other symptoms that we may see: strabismus, that's the malalignment of the eyes, kind of that cross eye, one eye maybe here, one eye's down here. Okay. Typically what we're going to see is one normal eye, and then the affected eye is the one that's going to be malaligned in whichever direction it may have gone. Okay. Heterochromia is different colored irises. If this is the condition that the child is born with, I mean, eye color, we can't really confirm until about 6 months of age. Not necessarily something that is a red flag. This is one of those genetic anomalies that just happens in some people that's not pathologic. But if it's combined with those other 2 factors, definitely something that just happens, something that we want to look into. Okay. If we look at late signs of retinoblastoma, would be blindness or any type of vision changes. This means that we're starting to get so much pressure from that tumor on that retina that it's going to actually sever that optic nerve. So our goal is to diagnose it before that happens, so we may be able to restore some of that vision. Okay, so direct visualization with the ophthalmoscope is going to highlight that leukocoria, that cat reflex. But also we can see what's going on in that area as well. CT, MRI are helpful to confirm. All right. As far as what we're going to do, if our vision is not affected, we're going to start with radiation and chemo. Okay. Chirotherapy or kind of freezing those cancer cells may be effective as well. If we don't diagnose this until vision changes are starting to occur or we're in full blindness, we may have to enucleate or remove that eye to prevent the continued spread of that cancer. Okay. If we take out that optic nerve, it means that there will be no vision in that eye. Okay. Nursing considerations, if we have to go that enucleation route, it means obviously family support is going to be a big factor here. Removing that eyeball is going to cause a lot of bruising and swelling in that area. So provide that information that this is something that is expected. Putting that surgically implanted sphere doesn't help any with the vision. All it really does is provide normal symmetry to the face. When the eyeball is removed, this eyelid is going to sink in. And it's kind of hard to look at, to be very honest with you. So putting that globe in is going to help. Doesn't do anything for the vision. As that area heals with that sphere in place, the child will be fitted for a prosthesis. Prosthetic device, depending on when diagnosis was, may be able to restore some of the vision. Okay, still may be legally blind in that eye, but may help to give some of that vision back. Okay, all right, that is the end of this lecture. Anybody have any questions about this stuff?
Are there any teaching considerations that we need to know for the fitting of the prosthesis for the eye versus like a leg?
No, not for the purpose of your exam.
Okay.
No, just, I mean, the big teaching point is that it may restore some vision, but still probably legally blind in that eye. That's the big point to take in.
And the strabismus, am I saying that right?
Uh-huh.
That's not always an indication of an retinoblastoma, right?
No,
Okay.
but if it's unilateral strabismus, it's definitely more concerning
Okay.
than if the strabismus is in both eyes. Yeah. All right, so we are going to go ahead and cover the grief and loss. This is a short lecture. I want to have all of tomorrow for our neurologic lesson. So we're going to go through this. This is chapter 36. The biggest thing to understand, if you struggled with Erickson on exam 3, he's not going anywhere. He is still hot and heavy on exam 4, except now his focus is about how that child, based on their development, is going to respond to death. Okay. So still have to be very familiar with him. I'm going to give you some great page numbers as we move through this that are going to help you really look at how that child will respond and how you as the nurse would respond. Okay. So a couple things to cover. Hospice, we focus on end of life care, as I covered in our oncology. With palliative care, the goal is really about making that patient comfortable. Our focus is on quality of life. We're not really trying to obtain any cures. At either point, hospice or palliative care, we know that our life is coming to an end. Okay, hospice puts a pretty strict time frame on it. We're looking at death within the next 6 months. Palliative care can go on for years. Okay. All right, so a couple ethical considerations that we need to cover here. In our first week of pediatrics, we talked about the difference between consent and assent. We also talked about how it can be difficult, especially with that older child, to decide, are we going to listen to the parents? Are we going to listen to the child who's, let's say he's had 7 bouts of cancer and he's really just tired of fighting, but he's only 10 years old. And by law, he's not really old enough to make his own medical decisions. Parents are pushing for further treatment. The child is telling you that he's done. It's an ethical dilemma that we often see related to hospice or palliative care in our pediatric population. It can be hard to get the child and the parent on the same page. Our goal is to support our child, right? If he's been through, years and years of treatment, he's telling you that he doesn't want to do it anymore. Although he's not old enough to make his decision, what we would want to focus on as the nurse in that situation is trying to help the parents or the caregivers see it from the child's point of view with the hope that they would relent and kind of follow with that child's wishes. All right. Very, very difficult thing to do. Huge conversation here. The other point is, if you see that bottom point, not offering treatment that could cause pain but extend life is ethically acceptable. But ethically acceptable and accepted by the parents or caregivers are two very different things. So it can be very hard to get everyone on the same page when it comes to how we're going to treat this child. I have seen these situations go to the point where they have to go to the ethical board of the hospital, and in that situation, based on how that child is representing his feelings and his thoughts, he may actually be awarded the ability to make his own medical decisions outside of his family. Okay. That's worst case scenario. Hopefully we're able to get everyone in agreement in that family, so it doesn't have to go to that point, because that really helps, really everyone understand that situation, kind of helps with that grieving process once that child is no longer there as well. All right. In our first week together, we also talked about how we need to be honest with our children. It's gonna be another difficult situation that happens as parents or caregivers don't always want us to be honest. If a child asks if something hurts, we want to be honest with that. If a child point blank asks you, am I going to die? Again, we want to be honest with that. We don't want to be, we don't want to scare the child, but we want to be honest with him. And I mean, the toddler, the preschooler is probably not going to put two and two together. But that school age child, that older child, he may start to see kind of where his life is going. I have seen situations where parents didn't want their child to know that they're sick. But children are smart and they start to put things together. And I've seen nurses put in really difficult situations where parents were mad that the nurses were honest when the child asked the question, but ultimately that's our responsibility. All right. So it may upset parents, but that we don't offer the information, but if the child asks us, we're going to give it. We follow the parent's lead as much as possible, but when that child is asking us for information, we give it. Okay, in the non-scariest way that we possibly can. All right, so now we're going to get into the specifics of how the child is going to respond. And this is where you want to be very mindful of how Erikson is going to fit in this situation. So these tables start on page 990 in the new textbook, 1015 in the 7th edition. This is going to be something that you really, really need to understand. Okay. So infants, they're not going to understand, right? They don't know that their life ceases to exist. Most of their response is going to be related to pain, right? So keeping them comfortable. Same for toddlers. They don't really understand. Everything is about them and how they feel about a situation, whether we're talking about their death or the death of someone close to them. They're really not going to be able to process it either. Okay. If we're looking at that toddler, they don't really understand cause and effect. So saying that their family member or whoever it may be has died, they're not really going to understand. So if we're looking at providing care, if it's not the toddler that's passing, that same thing that we talked about in week 1 with routine and structure is very important here. Consistency amongst our caregivers, whether it's the child that's dying or a family member that's dying, is something that we want to promote. We think about that separation anxiety, that attachment that goes on in this age group, in both the infants and toddlers, and that consistency is something that we need to provide for them. Okay. Moving on to our preschoolers, remember we talked about how they may see illness as a punishment. They did something bad and they're being punished. They can take this further into that death. They're going to die because they weren't nice to their brother, or because they stole that piece of candy, or whatever they deemed as their reason there. Okay. they may understand the light concept of death, but they may also see it as a temporary thing. All right. Think about, if you've experienced this with your own children, your grandparent or someone in your family died, they tend to see it as a temporary thing, right? I can remember a situation with my nephew. He was 5 when his grandmother died, and his parents explained it, Nana's gone to heaven. And his question is, oh, okay, when can we go to heaven and visit? So they don't really understand. They don't make that connection. They understand that they're somewhere else, but they don't necessarily get to push it all the way to they're never coming back. We can't go to where they are. Okay. Same thing here, maintain that routine, minimize that separation from parents or caregivers. And through all of these things, providing care for the family is important as well. All right. That anticipatory grieving that happens, knowing that their child is going to die is a big factor, something that we would have to work through. Okay. The school-age child may still think that they're being punished, but they start to have a better understanding that death is the end. They're not going to see this person. They're not going to exist anymore. There's nothing that is going to happen after that, as far as what they're aware of. Okay. They may see death as, we talked about that magical thinking. They may kind of personify it in some scary type of image as their way of processing it. Okay. A lot of parents will ask, not necessarily for the child that's dying, but maybe for siblings, or if you're working in a pediatric setting, they may ask, when is it appropriate for a child to go to a funeral? And that's a really hard thing to to answer. Because children do process things differently. I mean, we can follow Erikson where they're at developmentally. That doesn't always give us a strict age on when it's appropriate or when, it would really be understood by what's going on. So if I were approached by that, I would just say, you have to do what you feel is right for your child. Under the age of 5, they're really not going to understand the situation. And they're not going to understand that whole saying goodbye. As the child gets a little bit older, it may help provide them with some closure. But that's a really difficult thing to have to decide as far as siblings or if it's someone else dying. Okay. Again, we want to be very honest, especially as that child starts to process things more in depthly. We want to be honest. If he asks, am I dying? We want to give him that information. Again, present it in a non-scary manner, but he deserves that truth. Okay. And then the adolescent, not exactly like an adult, but starts to have that deeper thinking, that better understanding. Again, Erikson in mind, the physical effects or those changes that the body may go through as they move towards death may be the bigger factor. Okay. Because that body image is so important to them. Privacy is going to be a big factor here, giving them time to grieve with you if they want you there, without you if they prefer that. Providing them with information as they ask it. And here we can go to that elevated level of being more honest, more frank with this conversation because they're able to process that information. Okay. All right. So from your point, the nursing considerations here, pain and symptom management, always huge. We want that child to be as comfortable as possible. This is our top priority. We're not trying to save that patient anymore. We've exhausted all efforts. We've tried everything that we could. This child is going to die. The best that we can do for them is keep them comfortable. Okay. When it comes to our parent and siblings, we provide education to the parent or caregiver to give that anticipatory guidance, that anticipatory grieving. When it comes to the sibling, we really have to follow what the parents want. Okay. If the parents want the siblings to be included in the conversation, we can absolutely do that. The difference here, if that child, the patient asks us, Are they dying? We have that capability of being honest with them based on the ethical guidelines of being a nurse. Okay. If the sibling asks, is their brother dying? Now we get ourselves into a sticky situation where we have to refer to the parents. We have no ethical obligations of being honest with that sibling. So if the parents decide to lie to that sibling, there's absolutely zero that we can do with them other than try to provide that parent with information on why lying to that sibling is going to be more harmful than beneficial as far as that child eventually processing his grief. Okay. But we cannot be honest with that sibling because he is not our patient. We do not have that same ethical protection there. Okay. As far as taking care of yourself, if this is something that you decide to go into, I mean, death is hard. Death is a part of nursing. You guys have probably experienced that where you're already working. It somehow is a lot harder when it's a child. Okay. If you work in an area where this happens often, the need to protect yourself or to look for ways to make sure that you're dealing with your own grief effectively becomes more important, right? As part of that respect, if parents invite you or want you to come to that service, that funeral service, that is absolutely something that you are able to do. That's your call though. Okay. I have been to baby funerals. They are really hard, but I know that the parents really appreciated that I was there. Right. The last thing that we have to cover is those physical signs of impending death, really something to be red flagged on. There's a great, I didn't put the page number in here. There's a great page, a great table in your textbook that talks about this. But loss of senses, those tactile sensations, sensitivity to light, we know that hearing is the last sensation to go. Our other changes, loss of senses, we start to see that change in our level of consciousness or understanding, muscle weakness, loss of control of our bowel and our bladder, decreased appetite and thirst. We're not going to push these children. If they're not hungry, they're not thirsty, it's okay. All right. The changes in respiratory pattern, you guys may have heard of Cheyne-Stokes respirations. What we see with this is that change in depth of breathing and periods of apnea. This is where we're really starting to get close to the end. Okay. You may also have heard of something called the death rattle. This happens very much at the end. And what we're hearing is air pushing past the secretions that are stuck here from lack of movement. All right. And then we start to see all of those vital signs slow down. The heart's not pumping very effectively. So the pulse is slow, the blood pressure decreases. And then in most situations, we just see that child kind of fade out. Okay. We can listen to the heart. If there's no heartbeat, we'd have to have that confirmed in most situations by a physician. If you work in some hospice centers, you may have access to do that, but most of the time it requires a physician. So I know we went over just a little bit, but I wanted to make sure that we got that in. So I have all of tomorrow to focus on our neurologic section. Anybody have any questions before I let y'all go? No? All right. Y'all have a great day and I will see you all tomorrow.